right, my name is Dr. Ben England, and I'm here with Dr. Raymond Butts and Grant Townsend from Nuvocell Biologics, and we're really happy to be kicking off our webinar series. We spoke with Grant, a couple of weeks ago about what Nuvocell was and how Nuvocell is kind of changing the game when it comes to rehab and conservative care, and we really wanted to just take the opportunity to start taking a little bit of a deep dive, looking more at maybe some of the cellular biology and some of the various topics surrounding exosomes and maybe how they fit into clinical practice. And then really over the course of this series, really be diving in more to the science. So Grant, thanks for being here. Ray, good to see you right next to me
Right next to
today.
you. It's like a dual session virtually.
So Grant, thanks for being on here.
Yeah, no, thanks for having us again, Ben and Raymond. Excited for some of the topics we're going to dive into today. I know we've had quite a bit of interest from our provider group as well on these webinars, so definitely looking forward to diving into it.
Yeah, it's kind of like the dual Torrentia tribe and Nuvocell and social media people. So it's kind of fun to have everybody here. So
Maybe the best thing to do is just for the people who weren't here last week. Maybe it's a good idea. Maybe Dr. Grant, if you maybe just introduce yourself real quick and just give us the premise of the company and what's going on. Just a quick once over the world, and then we can do the deeper dive.
Yeah, that works. I can do a quick intro recap. Full disclosure, though, I'm not a doctor. But no, just to recap. So I know last webinar we did a little bit of an introduction on what Nuvocell is, the mechanism behind our product, and why we do what we do. So to start there, Nuvocell is a topical transdermal exosome-based product. What we have done is taking the mesenchymal stem cells from the Wharton's jelly of donated umbilical cord tissue, which are commonly used in injectable therapies today, stem cell regenerative medicine. And we focused on the exosomes, which are growing rapidly in publicity and therapeutic potential right now in the medical community. By taking those exosomes, because they're nanovesicle protein carriers, we're able to encapsulate those in lipid nanoparticles to stabilize them and also help them penetrate through the dermis and then formulate them into a topical cream with some other natural transdermal ingredients so that you get the same benefits as the injectables, but in an easily applied topical cream. So that's the name of the game for Nuvocell. The reason we're here and we do what we do is it starts from my personal story of a failed back surgery I had at a very young age that ended my collegiate basketball career. And from my own struggles of living through pain every day and trying to figure out how to fix my back after conventional medicine failed me, I was introduced into stem cell science and was blown away and have become really obsessed with it ever since. So our mission here at Nuvocell is to make regenerative medicine more accessible and more well known to the public so that people don't have to go through what I went through. So that's why we're here, and we're excited to be partnered with the Torrentia group, who I think share a very similar mission and drive.
yeah, Ray and I really started Torrentia because we felt that rehab was going in a really unique direction. We know kind of the long-term data on surgeries. We kind of have seen where surgery has sort of failed. We've seen where the opiate epidemic has really left us in terms of patients that are dealing with pain on a daily basis. And what Ray and I felt that exercise and conventional physical therapy was actually wildly inefficient. After the 12th or 16th visit, you're still trying to give people their exercises and apply correct loading principles and really kind of work through the process with those patients. And sure, you built a great rapport with them. And then maybe you started dabbling in some dry needling and some advanced, therapies and really found that it was effective, much like Ray and I have. And what we found was not only was adding biologics to the mix better for your patient, safer for your patients than surgery, less downtime for your patients, but we found that those patients really benefited not just from the biologics and the therapy, but also adding technology to it. So what Ray and I did is we kind of came up with, okay, what are the most evidence-based technologies? What are the most evidence-based and I would say accessible, biologics? Many of our patients, Grant for exosomes and others, they were flying to other countries, they were spending tens of thousands of 15s of thousands of dollars seeking out these treatments. And while there was great outcome or where there were great outcomes for those patients, we found that the cost seemed to be a barrier, which is why Nuvocell, for us really brought together some of the same, mindset in terms of it's accessible, it's affordable, practices can add it tomorrow, and patients can start getting better this week with the combination of the right rehab, the right technologies, as well as adding biologics to their practice. So that was really how this, we'll call it webinar series was born. This relationship was born. And Ray really works thoroughly to make sure that the evidence and the data behind what we're doing is tip top, in terms of evidence-based, most up to date, and really how all of those technologies work and how the research fits into clinical practice. And really what I do more is, okay, now that you're doing this in your practice, how do you not disrupt your flow? How do you make sure that your practice is successful? How do you monetize certain things in your practice to make it efficient? Because we know profit margins are razor thin. Most clinicians are looking to add cash services and other things. And we really just wanted to create a program and partner with people like Nuvocell who really have that mindset of the next version of medicine. And, just, back in 2018, kind of was big, for the biologic community and some of the exosome community. And, the world started exploding, but we're now almost 10 years, into that. And many practices, just like last week on our webinar, many people didn't even know what exosomes were. So we hope that this webinar series serves as a good, grounded, foundational starting point for people. And as we've married, Nuvocell into the orthobiological hacker program, and we've done that, we're really just happy that we're able to do this for people as a source of truth as we all kind of navigate these waters. Ray, anything you want to add to that?
No, I mean that was pretty good, honestly. I'm glad we have that recorded. Maybe I'll just start off with the first question. So, we know that exosomes are filled with a whole bunch of different chemicals, communication from stem cells. And so the reason why we're putting them into the tissue is so that we can really provide those instructions to other cells that are in the area in order to be able to orchestrate a better repair. So could you maybe just give us some of the things that are found in exosomes, which are those signaling molecules? And then maybe just talk through a little bit about how those signaling molecules are released from the exosomes, and to include like the temporal aspects of that, like from using the cream, like what the expectation is as to what those are, what the chemicals are, how they're released over time, and what the expectation is that they're going to do.
Yeah, that's a great starting point. So, the beginning of your question, what are the specific proteins? I know we touched on this in our last webinar. So, there's a small set that we test for specifically in our product. Now, that being said, naturally in exosomes, there are hundreds of different types of proteins, growth factors, cytokines contained within those exosomes, and obviously that composition is dependent on the source of the stem cell that you're getting the exosome from and the environment in which the exosome is extracted, right? So just to list off a few that, for example, we test in our product. I got to read off my cheat sheet here, but alpha A2M, alpha 2 macroglobin, thymosin beta 4, T beta 4, hepatite growth factor, HGF, vascular endothelial growth factor, VEGF-A, interleukin 10, IL-10, insulin growth factor 1, IGF-1, transforming growth factor beta 1, TGF-B1, decorin, TNF stimulated gene 6, fiberglass growth factor FGF2 and FGF7. So, Ray, you'll probably know better than I do the specific roles of each of those. But in general, those cover a range of different roles from inflammation modulation, tissue repair, extracellular matrix remodeling, right, depending on the use case they're being introduced to for. And then the second part of your question, which was, how are those proteins released and delivered? And to me, this is one of the most fascinating aspects of exosomes. And
It's all right. Maybe we're experiencing some technical difficulties temporarily. Well, we'll just jump right in then. So, some of the primary purposes of those cell signals that really come from exosomes is if you really take a look at what's happening, is we're not really talking about putting topically the actual stem cells on, right? Like we're putting essentially these extracellular vesicles that contain all of those peptides and proteins that really that Grant had just mentioned, and really all of those play an important role when it comes to rehab, as it pertains to tissue healing, as we know how they fit into the inflammation, proliferative, and really the long-term, maturation phases of healing, and how those vesicles work. Ray, do you want to tackle some of the pathways and different things? I think that would be helpful, kind of where Grant left off.
Yeah, so I mean, look, I mean, so many of those things that he listed really become extrinsic signals of, different receptor types on lots of different cells, to include stem cells that are in the area. And those receptors can come in lots of different varieties. They can be ionotropic receptors, or they can be metabotropic receptors. Ionotropic receptors just let ions come in cells. Metabotropic receptors, they work on G proteins, so they're G protein coupled receptors. But the end result of all of those extrinsic signals is kind of the same. So they really activate a cascade of events which are based on different enzymes that kind of work, in synchrony. And those different cascades are associated with lots of different pathways. So we've got the MAPK-ERK pathway, we've got the AKT pathway. So a number of different pathways, which essentially they work through and end up in transcription factors. And those transcription factors are typically AP1, NFK beta. And the transcription factors are really then responsible for transcribing the parts of the genes that are necessary to make the proteins inside the cells that are truly responsible for the proliferation of those cells,
11.6 is 50th percentile for
differentiation of those cells, and then they're also responsible for a lot of the recruitment of cells to the tissue that are necessary for repair. So if you think about it, those are truly the transcription factors that started with, a lot of those extrinsic signals that were packaged inside those exosomes. And those are really what are responsible for, eventually the cascade of events that get us to the proteins that are really responsible for everything that we want to happen in order to make, repair as efficient as possible. So, yeah, I mean, what's really interesting for me is that long list of things that he read there. I mean, that it really rivals, and I would say in some cases, I mean, that list is even longer than many of the same extrinsic signals that you would find in platelets. And I mean, if you think about it, the whole reason for PRP injections is, I mean, you're injecting a lot of platelets, all in the same place, so they're in concentrated form, with the idea that those platelets will really do two things. Number one, they provide like a sticky sort of a framework base or matrix by which stem cells can come and stick to and stay around in order to do their job. But two, they're like little deployment packages, right? Much like exosomes, they're filled with all kinds of growth factors and fibroblast growth factor, human growth factor, all kinds of different things that are platelet-derived growth factor that are released from them. And either they do specific things to provide these extrinsic signals to specific cell types in order to get the desired result, or they almost work as a honing or a beaconing mechanism to call stem cells to the area, which then in turn, provide the repair. So it's interesting to think about exosomes in that way because, if they are these little vesicles of, all these different signals, these little deployment packages, and we're really able to do that within the context of conservative care, and then add everything else that we're already doing to that, right? Then the real questions that we're trying to ask is, can we really make some of the outcomes on par with PRP? Especially if we can start to push those exosomes deeper into the tissue by using a lot of our technologies, if we can start to push them to release a lot of those signals in a way which is, temporally correct, what is it that we can do to really exaggerate what those exosomes are already trying to do at the place in the tissue that we want them to be, and in a way which is optimal in terms of time, so that we can really up the game on what we do too.
Yeah, and with Nuvocell, I mean, some of our early conversations with Grant were we realized that, Grant's mind had already moved to where our minds were, which is okay, if we know that patients are seeking care for biologics and stem cell therapies, then what does the rehab need to look like before, during, and after? And that was really how the orthobiological hacker was born was, well, what do we do before PRP injections with our patients? What do we do during, kind of the care within the first week or so? And then what do we do for the long-term follow-up for those patients? Because as we know in the literature, like many of the studies on mesenchymal stem cells, specifically bone marrow-derived stem cells, the outcomes are there a year later. The outcomes are there in 2-year and 5-year follow-ups. And even on par with surgery, some of those outcomes, depending on the study you read, depending on the condition you're talking about, they're also wildly inefficient. But many biologic therapies are made more effective, and patients see faster outcomes when married with class 4 laser, when married with focused shock wave, when married with radial pressure wave, when you apply exercise using direct current technologies like ARP wave. And what we see is a combined multimodal approach is really the way forward. And really through the series, we're going to be breaking down why that is. Why is it that our outcomes are better when the therapies are combined? And, even next week, if some of those pathways and signaling pathways interested you that Ray was discussing, I mean, we're going to really break down the cellular pathways in our next webinar, because we could talk for hours just on a singular pathway alone. But hopefully everyone can kind of start to see the premise of why, and really the importance of exosomes is, one, they're efficient. There's not a lot of downtime in terms of application, but two, they fit right into the context of what you and I are already trying to do when it comes to dry needling, shockwave, ARP wave, and other connective tissue, interventions and other biologics.
So sorry guys, I know I dropped off there for a little bit. My power actually cut out at our brand new facility. But I'm back on now on my phone.
Grant's back.
Sounds suspect, but all right.
He just dropped the mic and walked away. So,
but again, I think where you had left, I mean, I think the question was, I wanted them to hear that list of things that you find in exosomes, because a lot of those things, I mean, you read about in research, and you're definitely hearing more and more about all those things. I would say the best example of that is the first one on the list, which was that A2M. I mean, A2M is really something that a lot of physicians rave about. I mean, they're really using that as part of their PRP strategy in osteoarthritic joints, and the results on that seem to be pretty amazing. But if you can imagine packaging that A2M instead of having to go through the entire PRP as part of the vesicles, and then being able to deliver those vesicles, those exosomes down deep in the joint, it may be over a longer period of time in order to get the same effect, because obviously we're not, injecting something into the joint, but to do it in a way where, we can package it as part of what we do and make it more cost effective for the patient is very cool. And to think about all those different chemicals as really just signals or extrinsic factors that have all these receptors on cells, which provide instructions to those cells of what to do genetically and how to act in order to drive the repair. I mean, if you think about it that way, I mean, really, all of these exosomes are really just all of these different instructions that give us the opportunity to orchestrate the repair as part of a much larger scope that we are already doing as chiropractors and physical therapists and all the rest.
Yeah, I think, Ray, you kind of touched on that, with the signaling, is we're really talking about, paracrine signaling, of really how the body communicates in cellular repair versus other biologics, at least with stem cell therapies. They're trying to replace cells that are dead or dying or broken with new cells. And because the differentiation process takes so long and the proliferation process takes so long of those stem cells, having the chemical signaling factors within the tissue, like with exosomes, for example, you start kind of a step ahead. Because with vascular endothelial growth factor and IGF and all the rest, those growth factors we see prevalent during the proliferative phase of healing. I mean, some of the interleukin factors, yes, we see, more in the inflammatory phases, but you're kind of starting a step ahead or one step further because at least with PRP, like many physicians are taking PRP and they're breaking it down into PRP lysate to try to make it in a smaller form or more usable form or bioactive form, if you will, which is really trying to take it that step further versus we've already got these small nanoparticles within the exosomes that are already capable of carrying out those signals and have those actual molecules and chemicals present within them, which is why we're seeing the outcomes that we are. So hopefully that answers some individuals' questions about kind of some of the differences between the two. And I want to demystify one thing too, is when you say proteins, another term for that is peptides. A lot of those proteins that are housed within the exosomes are actually peptides that people are seeking out. And many of those peptides are included because all peptides are small to medium-sized amino acid chains, which make up proteins, but they're specific proteins that carry out a specific function, like thymosin alpha and thymosin beta and some of those that you mentioned already within the exosomes.
But it's interesting to note that how cells act are really dependent on the proteins that those cells transcribe, right? So you're almost using paracrine factors, which are coming from these exosomes, in order to be able to get cells to genetically make other proteins, right? Because those proteins then will drive that mission of the cell. And I think it's also important to say that not only do we have paracrine factors, but we also have autocrine factors, right? So that's basically signals that are created by cells that are released by cells that activate the same cell. And classically, a lot of these paracrine factors that were listed off that are packaged in these exosomes, they really drive the ERK and the AKT pathway, which ultimately gives us transforming growth factor beta. And transforming growth factor beta is kind of the ultimate autocrine factor because it provides a positive feedback loop to all of those different cascades, which like double and triples down on the transcription of, all those things that I talked about before that are really necessary for regenerative medicine. But also transforming growth factor beta is it also plays a big autocrine role in the creation of VEGF and for angiogenesis, which is also huge when it comes to what needs to be done to set the stage to ultimately allow that tissue to heal. And transforming growth factor beta is really what's responsible not only for the activity of fibroblasts and keratinocytes and all of these connective tissue cells to do what they do and make collagen fibers so that we get better connective tissue repair. It also ensures that those cells don't overly act and start making excessive fibrosis and scar tissue, which will ultimately be detrimental. So, I mean, we could go deeper and deeper down this rabbit hole, but the point that I'm trying to make is that all of those things that I really wanted Grant to list off that are packaged in exosomes, they have so many different roles when it comes to repair. A lot of those are direct things, but many of them are indirect things that are 2 or 3 chain deep before we actually see. But they're so much more powerful, I think, than what many clinicians even appreciate.
I think one of the key differences too that we want to point out, with a product like Nuvocell is it's not just a singular event. meaning many of the biologic therapies, like what I would see is patients would have, bone marrow, aspirate concentrations or BMAC procedures or adipose-derived stem cell procedures. And the patients are miserable for a couple of weeks sometimes, with those interventions. And it's one singular event versus like with Nuvocell and the exosomes that you're using with patients, you're getting that twice a day, over a 30-day continuum of exercise, and for more chronic conditions, maybe for 2 straight months or 3 straight months of really utilizing those paracrine and autocrine factors to kind of marry that with the rehab that you and I are already carrying out with those patients. So it's just one other point to make.
I mean, everything that we do in the Orthobiological Hackers series is to really talk through all the different manual therapies and all the different technologies and what all of those things do in order to continue to provide both intrinsic and extrinsic factors to cells so that we can maximize what the physicians are trying to do with their PRP injections and with the stem cell injections. But now to be able to use the cream that Grant is talking about to not only be able to do that in the clinic, but to also be able to do it in the in-between times where the patient is not in the clinic and they're doing it at home. I mean, they're essentially continuing to provide the same instructions that we are trying to maximize with focus shockwave and with laser and all of the other stuff, and do it continuously, over the weeks and months after the orthobiologics that the physicians are doing. I mean, that's exciting. I mean, the power, the implication of that is huge, especially given the fact that there are really two things in regenerative medicine that are thought to be the primary limiting factors, right? One of those things we know is the conversation of what needs to come after the orthobiologics, meaning the stem cell injections and the PRP and all of that, and what that looks like in the weeks and months afterwards to ensure that those cells stay alive, they continue to get their instructions, we optimize what they do, they continue to proliferate, they migrate, all the things, right? But that's why this cream, I think, is really exciting in particular, because I think it really compounds what it is that we're already trying to achieve, whether you're a chiropractor or a physical therapist or, whatever it is.
Yeah, Grant, do have a question for you, because I get asked this a lot. Like, we're really talking about, correct me if I'm wrong, these products are cell-free. Can you talk to me a little bit about what that might mean? I mean, some of you probably are well versed in this, but kind of the major differences between a stem cell procedure versus a cell-free, intervention. I mean, could you maybe just give me the highlights on between the two?
Yeah. Simply put, a cell-free product, which you'll see in our website and posted various places, is a product without the cell itself, right? So basically, what we do is filter out the stem cell and keep the acellular matrix that the stem cell itself secretes, which are the exosomes and the protein complex. So there's a couple of there's many benefits to that. One, starting on, from a risk factor perspective, obviously a cell-free product like ours is not going to have, full DNA strands or things of that nature. So the risk profile of immune rejection and tumorigenic capability is going to be much lower. And then two, there's really three main ones. Two, from a production and scalability standpoint, exosomes, as you see in our product, after they're encased in lipid nanoparticles, are able to be stored at refrigerated temperatures versus ultra low temperatures, which are down to negative 80 degrees Celsius, which from a cost perspective is much more cost prohibitive because you need liquid nitrogen storage and dry ice shipping. And then three, from a delivery method, because the product is cell-free, the size of the proteins, the size of the exosomes are obviously much smaller than the stem cell itself. I shouldn't say there's no way. I would say it's very highly unlikely that you can get a stem cell to penetrate through the skin, without completely cutting or disrupting the skin. So by taking those nanovesicles, we're able to disrupt the lipid bilayer of the skin by using some solvents to let those exosomes penetrate the dermis. Also, naturally, exosomes they are a lipid bilayer themselves, so they have some elasticity to them to where they can flex and be able to get in between the dermis and through. So those are the three main benefits and the difference between cell-free and cell products.
That's great. Thanks, Grant. Go ahead, Ray.
So we know that the way that we start to change the genetics and the way that we get the proteins that we want in cells is first we have to go through replication, then we have to go through transcription, which creates the messenger RNAs, and then finally we do the translation where we go from messenger RNAs to putting amino acids together to make proteins. I think it is particularly interesting that one of the contents of these exosomes is actually messenger RNA and microRNA. A lot of those extrinsic signals are really driving all the different steps that I just mentioned to you to get to the end. But it does seem like some of the things that we find in exosomes are really skipping the line, more or less, right? And they're going right. We're delivering immediately messenger RNA, which is going right to the translation phase. My question is number one, what's the difference between microRNA and messenger RNA? And number two, do we have any idea what those messenger RNAs are responsible for in terms of the proteins that they create? And are any of them thought to be associated with cell proliferation?
So those are three really good questions, and you'll probably, to be honest, you may know the answer to these better than I do. To start with, the difference between microRNA and mRNA really has to do with the length of the sequence or the length of the strand. Correct, right? So
Absolutely.
it's not a full. It's a shorter strand complex that is really starting a signaling process for protein composition and protein production in the cell. So to answer the first question, now I'm getting a little bit outside of my knowledge of microRNA versus mRNA, but I love this is going to be good additional research for me to do.
I didn't mean to do that to you. I was more interested that I know that when it comes to stem cells, which is, one of the things that we're ultimately trying to assist in an additive way with these exosomes, that, we're really trying to do one of two things. Either we're trying to get stem cells to make more stem cells, or we're trying to get stem cells to differentiate into the cells that we need in order to drive the repair, right? And so I know that when it comes to the differentiation part, a lot of those come from extrinsic signals and then compounded with some of the intrinsic signals that come from obviously inside the cell. But I just think it's fascinating that some of the messenger RNA that we're actually using with these exosomes are actually coming from these umbilical stem cells, and I'm fascinated by what some of that messenger RNA could be responsible for. So that might be a conversation for a later time.
Yeah, and I know this is a topic that we get asked pretty often as well, especially because we use LNP technology with our product, the lipid nanoparticle technology. So obviously that's closely associated with the mRNA vaccine, which is a very, very different thing. So I just wanted to make that that statement, right? These aren't synthetic mRNA molecules. Sure. We're not doing any type of gene editing or modification for targeted delivery.
Sure.
These are natural microRNA and mRNA molecules from the donor tissue.
Yeah, so we have a question, Grant. I mean, I'm going to guess this is more of a question of the delivery mechanism, but how can we be sure that exosomes in a topical cream are actually functional? And normally, if they're not properly cryopreserved, the lipid membrane can degrade, reducing the stability. So do you have any comments to make on that, as you're well familiar with your product, in terms of how it gets through the skin and, the lipophilic properties and all of that?
Yep. So the answer to that question, that's the one of the 50% of the reason we use a lipid nanoparticle encasement process. So we use a natural phospholipid based lipid nanoparticle to encase the exosome, and what that is doing is basically is putting a protective fat layer around the exosome that's going to preserve it. And it's similar technology to liposomal technology, which is becoming very popular, right? So there's quite a bit of science and research out there showing that that lipid nanoparticle, once encased, it's going to stabilize that exosome at refrigerated and room temperatures because it's encased in that phospholipid, that fat based layer. What that also does is, because exosomes are a lipid bilayer in themselves, it's basically creating an extra protective layer around it, which is going to help with absorption through the skin as well. That's when I talk about elasticity, right? Being able to maintaining the elasticity of the exosome so that it can penetrate through the lipid bilayer of the skin to get down into the musculoskeletal structure. So that's the main mechanism, right? And then we also do a lyophilization process as well. So lyophilization of exosomes is become very popular to create a shelf-stable exosome product, right? Because basically you're just doing a rapid freeze dry of it, and then once you have that freeze dried product, you can reconstitute it. But by encasing it, lyophilizing it, and then formulating it, we're able to protect the lipid bilayer of that exosome to keep it intact until it's delivered to the skin.
I would also add to that too, Grant, and I think you'll probably be able to answer this, is you're not making these creams in your basement. You're making them
Definitely.
in
At least we don't
Yeah.
think.
you're making them in a FDA approved lab and some of those things. Like you guys are going through your due diligence in terms of
Our
batching and certification process and all of that.
Yeah, our formulation process is actually very, very finicky. So we do everything right now is done in an FDA registered lab, right? And with our process, because we use DMSO in our product to promote transdermal absorption as a lipid bilayer disruption, that actually we have to do a homogeneous mixture with our formula. And that the reason for the homogeneous mixture is for people who know, exosomes on this call, DMSO is a solvent, right? It's a powerful solvent, so it's going to naturally, disrupt lipid bilayers, but it can also denature exosomes.
Yep.
So there are a couple points. In one, the extra lipid nanoparticle we put around the exosome will protect it, but two, by doing a homogeneous mixture in our product, we create little micro pockets of DMSO, because we basically want those little micro pockets to open up the dermis and then allow the exosomes to pass through. So it's actually it's a pretty complicated process, and I've learned quite a bit on it as we've started to ramp up, because it's something not every manufacturer can do.
Well, that's a good question. Do you have the name of the lab or which FDA lab?
So we don't disclose the name of our lab for confidentiality reasons. I will say that they're located within the United States, FDA registered lab. They've been around since 2018. So they're one of the few labs that made it through the big FDA remediation that happened in that 2016 2018 period.
Yeah, for the person that said, they missed the beginning of it, good job still seeing patients. That's great. All of the webinars will be available for review, either on YouTube or within the Torrentia tribe, and we can go through that kind of at the end. So everyone will be able to go back and rewatch and kind of see that for replay if you missed parts of it, as some of you came in a little bit late. I know everybody's seeing patients and different things. One of the last things that I think we should get to, because I think it's really a hot button topic, is what are the primary drivers of why patients are seeking exosomes, as a treatment option? I'll go ahead and start. I would say that most of my patients, either due to AI or the ability to research, many of my patients are very well read on many of these topics when they're coming in to see me. Meaning they've already done studies on kind of like the differences between PRP and maybe another biologic. They're coming in and they're already asking about peptides and supplements and, should I do this infusion and fly here and do, I mean, they're very well researched now with the use of technology, which is great. What are some of the other ways that you're seeing, or what are some of the other reasons why people are coming in seeking exosomes, Grant?
Yeah, I mean, I've got a lot of opinions on this because of my past, failed back surgery experience. But I think we're at a tipping point in modern medicine right now where it's a combination of we've gone through the opioid crisis, right? We've gone through the COVID crisis, right, and now we're starting to see all the data come out about true failure rates of back surgery, for example. This is one of the most fascinating facts to me, but failed back surgery syndrome is a registered diagnosis. It's the only diagnosis that is due to a failed medical procedure. So, I think the combination of all these things snowballing and, people inherently having mistrust in the traditional medical system. I can speak from that because I went through it myself, right? As a 19-year-old, high school student who was trying to figure out how I could get out of back pain so I could sleep every night. And, my doctor promised me that a back surgery would fix all my problems, and it didn't. There's a lot of, distrust that comes from that too. So I think, people are taking their health into their own hands, right? They're doing more research. They're trying to figure out what are natural ways I can heal besides taking drugs, besides doing surgeries. And, I think it's opening the eyes to a lot of people. It's been very eye-opening for me over the past 12, 13 years, right? And I think we're in a mass realization.
And Ray, anything to add? Why are patients asking you about exosomes, or maybe how are they getting information? I mean, I've seen the number of webinars and infomercials and different things. It just seems to be on the rise. I mean, it's kind of crazy to see kind of the regenerative space take off. But
Yeah, I mean, obviously it's huge on social media, and patients feel like they're able to get it in a way which is easier, and they see that the cost isn't quite as much as what it would be for a PRP or a stem cell injection. And so for most patients, they like to start there. Before they go all in, they want to see if this is something that could help. But yeah, I mean, there is nothing but, I think, an exponential amount of excitement about this sort of stuff. I'll tell you one question that I do get quite a bit though is, as they start to use this exosome cream and they rub it in and now it's penetrating down into the tissue, what is kind of the timeline look like that lipid bilayer begins to break down and disintegrate, releasing everything that is inside to the outside? And are there some variables that we're able to play with in a conservative way, meaning like in physical therapy or whatever, that we may be able to do some things to make it so that either we can make that bilayer break down quicker and therefore facilitate a quicker effect, or in some cases, we can really try to preserve that lipid bilayer and get the exosomes deeper into the tissue, maybe closer to the source that we actually want to treat. So there's some variables that we could think about to kind of be able to manage what those exosomes are doing in terms of the timeline of releasing the goodness that's inside.
Yeah, I think the two biggest things that come to my mind are laser or red light therapy and shockwave. So if you look at the mechanism of action behind those two, red light therapy or laser therapy, heat, right? It's going to promote vasodilation in the application area. When you promote that vasodilation, it's going to increase absorption rates, right? It's going to open up the blood vessels in the application area. And then two, I know we've talked about this before, but using shockwave after, right? Basically a focal point that you're shooting down into the joint is going to help drive those molecules to the targeted area. I think the critical point to know is we want we want the lipid nanoparticle to be preserved as it's going through the dermis, right? So I think you mentioned this last webinar, Raymond. Laser therapy after application may be negative because those lipids are going to degrade with heat. So you don't want them to be degraded too fast. We're doing some testing on this currently to get some more clinical data in terms of how long that absorption takes. Currently, we recommend an hour after application before you go and jump in a pool or take a shower or anything like that to make sure that you're getting proper penetration. But we are conducting some testing with a third-party lab to really put some data behind that so we can know what the true absorption rate after application is. Is it an hour? Is it 30 minutes? Is it 2 hours? So that's all, that's stuff that we're working on currently.
I mean, I think one thing that Ben and I have really been thinking through a lot is, does the lipid aspects of the exosomes, is it really going to disrupt the beam from the laser in a way where, it's going to make it so that the laser is not actually able to get down to the cells that we want it to get to, right? Because we know that, usually fat and tissue can really be a big deal in terms of the penetration of laser, right? So, I mean, we've been doing a lot of reading about this, and obviously, we're collectively, working on this. So this might be also a conversation for a different time, but just with the understanding that a lot of that photobiomodulation is really meant to get to the enzymes in the mitochondria and really meant to fix the electron transport chain, kick out the nitric oxide, maximally make ATP, and really then work with a lot of the intrinsic factors which activate, the same genetic pathways that I talked about before. I wonder if it makes sense in an additive way to actually do the laser first, drive the ATP production from the mitochondria, and then in an additive way, add a lot of the extrinsic signals, the paracrine signals that are coming from the exosomes to the intrinsic factors that we're actually stimulating with the photobiomodulation. That was a lot. Sorry.
No, I think that's spot on. I love that. I think you're exactly on the right track with that, Raymond.
But I also think that you're right on the money there with the shockwave. I think just the mechanism in the shockwave that reverse order is more likely.
All right, so to
Sorry.
really keep us on track, we do have a lot of questions. So, does the FDA consider exosomes to be a drug? I would say, does the FDA consider exosomes to be a pharmaceutical? I think that might be a question. Go ahead, Grant. I'll let you answer that.
Yeah, so the answer is no, right? There's no FDA approved exosome product on the market. So, when you are doing marketing, we pay very close attention to this. We provide full marketing packages to all of our providers. We actually have a claims bank in there. We conduct training on this as well. So, we have approved claims that you can make around the product. I'm looking at the comment right now, right? Like,
could you maybe have Janae? I don't know. I'll pick on her or so. Or would you like to field it? Like, give us an example of an approved claim versus maybe something you shouldn't do. Sorry, Janae.
No, I love it. Can you guys hear me okay?
Yes.
Yeah. Okay, fantastic. So an unapproved claim would be that Nuvocell is going to heal your body with stem cells, right? So that's a pretty, egregious claim to say. What we would want you to say is Nuvocell is going to support your body's natural regeneration process.
Perfect.
Yeah. So, and like I said, we have a documented claims bank with this. And whenever you're doing this regulation FDA, it all comes down to the exact word, or if you're putting a "the" in front of supports or really minute things like that, right? The biggest thing is that the promote, supports, enhances verbiage is used, right? And then the other thing too is you know, content that's used online, right? That's what you want to be more careful of. That's typically what, governing bodies are paying a closer attention to. But, things in clinic and, one-on-one conversations, there's obviously less risk with that.
Yep. No, that's always a great question. I mean, I would encourage everybody on the call who does any sort of marketing to always check that you're marketing the correct things. One of the things that we get asked a lot about, like Focus Shockwave, for example, is it does have FDA indications for plantar fasciitis and lateral, tendonitis, in the elbow, so more of like a issue with the extensor carpi radialis brevis. So marketing off-label use can really get you in trouble if you're not aware of FDA indications. So it's always important to add your disclaimer of it's not meant to cure, treat, or prevent any disease. That's always good verbiage at different times. So just be aware of that. And that's any intervention. Notice I just said shockwave. I'm not just talking about exosomes when it comes to your marketing. Another question that we had
This is
is
a good one. This is a good one.
yeah. Because previously, the practice that I worked with, a physician, we routinely would recommend DMSO to patients, as a great way of aiding or assisting in their rehab process. And there are some studies to support the use of DMSO and CAM4 in terms of tissue healing. Do you want to maybe talk about maybe how some of the differences with that grant, is the benefit really coming from the DMSO and the camphor is the question versus the exosomes? I know that's kind of a tough and loaded question,
That's
but
an authentic question.
No, it's a question we get often, and it's a valid question, right? Because DMSO naturally going to have anti-inflammatory properties. DMSO, in the past has been used for osteoarthritis. So a couple points on that. One, the percentage of DMSO we use in our product is very low, less than 5%, because we just want to use that as a penetration enhancer. So typically when patients use our product, typically we recommend for exosome to start working, right. You're not going to start seeing those regenerative results until 2 to 4 weeks out. But I think some people see immediate results, and it could be from two things. And I've talked to quite a bit of doctors about this, right? Whether it's the DMSO with inflammation, or it's the cytokines in the exosomes that are modulating inflammation as well. So I think the main thing to know is typically on DMSO products that you apply, because I used DMSO in my past whenever I rolled my ankles playing basketball to get that swelling down, is percent DMSO, right? So ours is 5%, so it's a very small concentration, and you're putting a very small concentration, or you're putting a very small amount of the cream on the area in the first place. So the amount of DMSO you're getting is extremely minimal. And then the second point with the case studies we have, like we're getting ready to publish a case study now on a gentleman who had a labrum and bicep tendon surgery, retore his labrum and bicep tendon, was completely immobile, 10 out of 10 pain, and then went on a Nuvocell treatment with PT and chiropractic. Within 60 days was 90% mobility, 0 out of 10 pain. Quite frankly, I don't think anyone's seen that out of using DMSO and camphor, right?
Icy hot's pretty good, man. So for the newbies on the call, just to give them an idea with your product, we know that there is a morning cream, there is an evening cream. Can you just quickly touch on the primary difference, and why is one strategic at one time versus the other?
Yeah, so the original reason that we had two different bottles, AM and PM, was there's actually a slight formula difference. So we did not have camphor in the PM formula. And then what we found in initial testing was that we were getting better results out of the camphor formula. And after doing a little bit more research, I actually came across that camphor is a penetration enhancer as well, similar to DMSO. So the belief there being that we were getting better delivery of our exosome cargo with the camphor product. So we ended up changing the formula to include camphor in both. So now the formulas are the same. And really the reason we kept the product format the same is when communicating this to patients, there's a little bit of a tack that needs to be used, right? In terms of you're not just, hey, this is a topical cream that you go and apply for 30 days, right? We position it as a 30-day protocol, so keeping it in a kit format to encourage patient compliance on applying morning and night. Kind of from a more of a psychological perspective. We ended up keeping the packaging and everything the same.
Awesome. Cool. Are there any other questions? I want to make sure we have enough time to get through the questions. For those of you that don't know, Tax Day, April 15th is coming, and that's when our next webinar is. So we'll be tackling kind of our next topic, which is really more diving into those cellular signaling pathways and
Tax
really
breaks for exosomes?
Tax breaks for exosomes, maybe. But we're going to really be talking through those cell signaling pathways specific to technology, specific to rehab, specific to exosomes, and maybe why we're not really thinking about it differently, but really how all of those work together in an additive way. So we're really going to take a deep dive into the AKT pathway, my personal favorite, the MAPK pathway, which drives very crazy, the ERK pathway,
which is the MAPK,
and others. So, any other questions from the Torrentia tribe?
Sorry, guys, that stuff obviously is my love. So I always resort back to that. I love that whole topic of conversation of the April 15th.
Yeah.
But
any other questions in the tribe or in the group chat? I'd love to answer them for you. If you want to get in contact with me, my email is just ben@torrentia.com. Ray's is ray@torrentia.com. Grant, you may have to share yours because I don't know it off the top of my head. If people need to get in contact.
Yeah, Grant at Nuvocell. Yep, Grant at Nuvocell Biologics.com.
Grant, I do.
You can.
Oh, sorry.
Go ahead.
No, go ahead. I was just going to share too. And anyone who's interested in Nuvocell, you can obviously go to our website, nuvocellbiologics.com, Nuvocell biologics.com. And then on the site, you'll see where it's I'm a provider, and then you can go register for a provider group. And then someone from our sales team, most likely Janae, will get in touch with you about becoming a provider.
Maybe a parting question. And this is a good one because it really goes full circle back to the questions that we asked in the beginning. But I would say the biggest question that I get from patients is, once I start using this cream and I use it in the way that is recommended, and I'm continuing to be compliant with my physical therapy and rehab program, like how much time taking this cream, before I should expect to see a difference? And let me say that, Grant, I know you don't know the answer to this question because it's different, but from the guy who has really the most experience using this cream in a way which is clinical, what has been your experience with most of the patients that you see?
So I'll give you a little bit of a long-winded answer here. So in general, we say 2 to 4 weeks, right? And that is the disclaimer there is heavily dependent on the case. So I'll use 2 examples, then I'll give a third example of myself. So 2 examples: one, a patient comes in with a tendinopathy, tennis elbow, inflammation, right? When they start applying Nuvocell, typically what we've seen is they'll start to see some initial pain reduction within a couple days, and then typically by 2 to 4 weeks they're completely fine. Right now, on a different scenario, say you have a 65-year-old patient comes in who has severe cartilage degeneration in the knee, maybe they're 10-20% cartilage left, knee replacement candidate. Obviously there's a lot more regeneration that needs to happen to restore actual cartilage height in the knee. And so typically those patients, we're going to recommend a minimum of 2 kits. Sometimes they're going to need two to 3 kits, and they may not start seeing results until after the first kit, maybe into the 6-week mark. So kind of give 2. So to generally answer your question, it really depends on the patient and it depends on the issue. And the reason it depends on the patient as well is if you have a patient who comes in and they have high A1C, they're going to have a slower response, right? High A1C is going to inhibit cellular activity. Same with metabolic rates, infections, all that kind of stuff, right? That you got to watch out for. And then last but not least, what I do now is right. I've severe back issue. From failed back surgery. I've gotten my back pretty much good now, but I still have occasional flare ups. Maybe if I've been sitting all day, or I was on a long flight, or I did something weird in my exercise. So what I do now, and I don't know if this is right or not, but whenever I get a flare up, I'll just apply Nuvocell 2 to 4 times, and then I'm good to go. So obviously that's purely inflammation related, right? But my experience, it works well for that too.
Awesome. Well, thanks so much for everybody for being on the call. Grant, thank you for your time. Ray, thanks always for your input. If everybody wants to see the replay of this webinar, it should be live within the next week. You can go to Torrentia.com and click on the tribe. You can join the tribe. It's completely free. There's no cost. You can look at all of our archived webinars. I mean, I think we've got close to 50 or 60 webinars now that are on there, all on the topics of photobiomodulation, shockwave, exosomes, peptides, you name it. We've had these discussions in depth with some of the leading industry experts. So feel free to get on there, Torrentia.com. Just go to the Torrentia tribe. I think Janae put up her email too if you guys have questions about Nuvocell or cell numbers in the chat. But would love to hear from you. If you're interested in one of the orthobiological hacker programs where we kind of marry all of these things together with exosomes and shockwave and laser and all of that, you can check out those course dates on our website too.
Next time too, Grant, I would love to ask you your perspective on, maybe some of the additive effects of functional medicine and some of the peptides that people are doing, given the crossover and the mechanisms with the exosomes. But that's a conversation for I already asked you too many ridiculous questions today.
we could get into it on that, and it's fascinating to me. It seems like everybody is asking about peptides now, and it's a queer shift in the last 6 to 8 months. But yeah, that's a combo for another time.
Awesome. You're awesome. Thank you for your time.
Thanks guys so much.
Yep, thank you guys.
Next time.